Testing one, two, three. right. Well, good evening, everybody, and welcome to this session of Therapy Ed's online office hours. As you may have noticed in the chat box, just a kind of a friendly reminder to everybody to make sure to mute your microphones unless you want to go ahead and ask a question, and you can use the chat box to do that, or you can just, yeah, you can go ahead and use the audio to ask questions and everything this evening. Um, it is right at the top of the hour, so we're going to go ahead and get started. I want to respect everybody's time, and this session is being recorded. It'll be posted to Therapy Ed's PT YouTube channel. You can also go to the Therapy Ed website and the preparation for the NPTE and on the online office hours tab. If you want to access any of the previous sessions, then you're able to do that. So yeah, happy holidays to everybody. And let me just go ahead and introduce myself briefly. My name is Tom Sutlive. I am on faculty in the Army Baylor University DPT program in San Antonio, Texas. If you take a look at the picture at the bottom right of the screen, um, our our program is located at Fort Sam Houston, Texas. It is an active duty military course, and my office is, or our program is actually located in the building right behind the medevac helicopter. You can see a little bit of my credentials in everything. I served for 23 years on active duty as a Army physical therapist. And so, as you might imagine, kind of the ortho, musculoskeletal, sports medicine population is the one that I spent the most amount of time with, and certainly clinically what I'm most comfortable with. And then went back to school, got my PhD in anatomy, and really focused on like neurophysiology or yeah, neuroanatomy and motor systems, and remember muscle fiber types and motor unit types and all that kind of stuff. And I've been a therapy ed instructor since 2011, and love what I do. Enjoy working with students like yourselves, and looking forward to spending the next hour with you. If you would, let's go ahead and light up the chat box, warm up the chat box. Can you type in there, let me know when you're going to be taking the NPTE? That'll be helpful in terms of knowing, what the audience is. And so, okay, a number of people, it looks like everybody so far has taken it in January. June, okay, so April, got a July person in there as well, a couple of April. So yeah, so that's helpful. So the majority of you are in that final push mode, that final intense study period in terms of your preparation, and others, for the person, Fiona, and I think there might have been somebody else, Annabeth. Yeah, you're going to be taking the exam in July. Uh, no substitute for early preparation, right? So we're glad that you're taking advantage. We're glad that all of you are taking advantage of these free online office hour sessions, and the one that we're going to be doing tonight. So let me tell you a little bit about the premise. Why I had decided, and I've done this for a few years now, but when I first put this presentation together, the reason that I did it is my experience has been that DPT students, for the most part, are really, really pretty comfortable with examination of the patient and taking a good history, performing special tests, interpreting those special tests, and interpreting all the information from the patient examination and history, and that leads to a diagnosis. And I think students are pretty good with doing the assessment and the diagnosis part and everything. But then, like we often see in our program, and I see in programs around the country, okay, now I've got this patient in front of me. I know what the diagnosis is. I know what the problem is. Now, what am I going to do with them, right? What is the treatment going to be? And so that is kind of the basis for the presentation that I'm going to do tonight, is to talk about Specifically on the NPTE, what are going to be some of those, what is the nature of the interventions question for the musculoskeletal section? And some of the ideas can probably be applied to other systems, maybe neuro or some of the other systems as well. But we're going to focus specifically tonight on interventions for musculoskeletal disorders. I think it's always good, and y'all, especially if you're going to be taking the exam at the end of January, you're very well aware of the content outline, the FSBPT content outline that went into effect in January of 2024. So for this 5-year iteration of the NPTE, the examination that you are going to be taking, then this is the content outline, and this is just a little bit of a snapshot. This is just the systems. There would also be the non-systems categories that would be kind of below this table on a PDF. So we what we do know is that the musculoskeletal system far and away is going to be most of the questions on the NPTE, 27% of the questions, 1 out of every 4 questions on the NPTE is going to be based on the musculoskeletal system. As a matter of fact, a little bit more than 1 out of 4. So you're going to be graded on 180 questions. And so we're looking easily at 45, maybe even pushing into that mid 50 range. And so that's the biggest chunk on the national licensure exam. And so this is the content outline, the breakdown of systems. And then we can look at it this way too. The big 3 categories would be musculoskeletal, neuromuscular, and cardiovascular and pulmonary. So that's 65% of the exam. So said another way, 2 out of every 3 questions are going to come from these big 3 categories, but we're going to focus tonight on the musculoskeletal system. And so specifically, when you look at interventions, you'll answer 17 questions, or you'll be graded on right about 17 questions. And again, if you're graded on 180, so the entire exam is 225 questions, you're going to be graded on 180 of them, then that's right about 10%. So 10% of the NPTE is going to be based on the topics, the kind of questions that we're gonna review tonight. So obviously, in an hour, I can't cover every possible type of question, but we're going to talk about what are some of the themes, what are some of the topics, where might those questions be generated from, and we're going to get some repetitions in. Y'all are going to answer 7 practice questions this evening. So this is also from the content outline, and specifically it talks about interventions. And I'm not going to spend a whole lot of time on this slide. Again, you can go to the website, you look at the blue font that is down at the very bottom of the screen, and y'all can go to the fsbpt.org website. But for the most part, what is written in the content outline is fairly generic, but it does give us an idea about, making sure that we study interventions across the lifespan and maybe some of the specific topics. But because it's generic, what I wanted to do is I brainstormed a little bit. And I was thinking, okay, what could the musculoskeletal interventions questions on the NPTE, what could they be based on? And so they could be based on impairments, right? In the question stem, there's a description of a patient and there's some specific impairments that are listed. And those will probably be pretty straightforward. We just have to think, okay, they're talking about these impairments. This is what I need to address in terms of the answer choices or whatever the correct answer choice is going to be. Timelines, right? So we've certainly got to continue consider the stages of soft tissue healing. Is the patient that I'm dealing with in the acute inflammatory stage, or are they in the remodeling stage, in the proliferative stage? Because, for instance, what we do 2 days after a person has had an ACL reconstruction is going to look a whole lot different than what we do 2 months after they'd had the ACL reconstruction. So there, there will be questions if they're based on timelines, then you should expect to see that the author of the question has included a time frame in the question stem, right? You're seeing them 3 days after the injury, you're seeing them 3 weeks after the injury, something along those lines. The questions that are based on a diagnosis, those are kind of nice because they tell you up front, hey, this is the diagnosis. And so based on that diagnosis, maybe it's based on the evidence, what how am I going to proceed? Clinical practice guidelines. So those kind of questions are, uh, I mean, there can potentially be questions that are based on the evidence. And I want everybody to hear me carefully tonight when I say this, because I get this question often. Students will ask me, they'll say, well, do we need to know the clinical practice guidelines for the NPTE? And the real quick answer is you don't necessarily need to know the clinical practice guidelines. You all know that the examination you're going to take is based on textbooks, right? So the questions have to be based on information that is in published textbooks. But more than likely, the clinical practice guidelines are going to include information that has been already been published in those textbooks, especially if a CPG has been revised, like maybe the initial clinical practice guideline, let's say like for adhesive capsulitis, it was published in 2013, but then there was a revision just a couple of years ago, right? And so the nice thing about clinical practice guidelines is that they provide some one-stop shopping for everything that you need to know about a specific disorder. And the practice guidelines themselves are long. They may be like 80 pages long. So you're sitting there thinking, oh my gosh, I'm not going to pour over those 80 pages. And you are correct. You don't need to pour over those 80 pages because every CPG typically has about a 1 to 2 page summary with all the grades of evidence related to an intervention or examination technique or whatever the case may be. So I encourage y'all to take a look at the clinical practice guidelines, and we'll talk more about those later. Safety, got to recognize, red flags. Am I dealing with a person with acute anterior compartment syndrome? Am I dealing with a person that has, sustained a fracture or an acute ligamentous tear, an Achilles tendon rupture, right? Or perhaps something that is sinister, like a metastatic lesion to the spine, or some other kind of systemic or red flag condition that may be masquerading as a musculoskeletal problem, right? Person has kidney stones, what are they going to complain of? They're going to complain of low back pain, right? And so we got to be able to pick up on that kind of thing. Then there are clinical prediction rules, like when to, manipulate somebody with acute low back pain. And in those clinical prediction rules, what you'll find is if my patient presents with this and this and this, then this is the intervention that I'm going to choose. Or there could be things like this would deal more with diagnosis, but the Ottawa knee rules, the Ottawa foot and ankle rules, those kind of things that are useful in terms of clinical decision making. Principles, how about, a patient with low back pain? And we can think about the centralization phenomenon or the principle of centralization. And so if I If I do a treatment on a person who has low back pain and they have what seems to be a radiculopathy or radiating pain into the lower extremity, and I move them into extension, and that takes away that lower extremity pain and it centralizes the low back pain. Well, we got to keep our antennas up and be able to pick up on those cues that are being described in the question stem. Exercise prescription, that's something else to consider. I think the ACSM guideline textbook is a great reference for that kind of thing. If we think about, parameters for resistance training or maybe cardiovascular endurance training or flexibility or those kind of things. Post-operative scenarios are certainly fair game as well. Pharmacological management, and then new to the examination that y'all are going to take. So new to the NPTE effective January of 2024 are going to be regenerative medicine procedures. So things like um, PRP injections, autologous chondrocyte implant procedures. And then I don't have it listed on this slide, but things like stem cell, right? Stem cell therapy, that all comes to mind as well. So regenerative medicine is new for the version of the examination that y'all are going to take. Um, so with that, I think what we'll do is we'll jump in and we'll start answering some questions. And then y'all can fire away. If you got a question about a topic along the way, then you can go ahead and ask in the chat box or just go ahead and ask out loud. But what I will do is with each one of the 7 questions that we talk about, then I'll make sure to review the rationale for the correct answer, and then I'll review some of the relevant information along the way. And with that, unless anybody has any immediate burning questions, then we'll go ahead and jump in, and let me get my timer ready and we'll start answering some questions. I'm going to give you about a minute 10, a minute 15 seconds to answer each one. And that's about on average the amount of time that you're going to have per question when you take the NPTE. All right, so maybe a minute 15, a minute 20 on the NPTE. We'll do just over a minute this evening just to kind of keep things going. Okay, and I'm going to bring up the other thing I'm going to do is y'all can, oh, sorry. Um, let me. Was I sharing a poll with y'all? Could y'all see a poll that was up or not? Oh, okay, sorry about that. So anyhow, now you should be able to see this poll, and you haven't even seen y'all. Some of y'all are answering. You haven't even seen the question yet, and so here we go. Here's question number one. Okay. That's a little bit more than a minute, so go ahead and start getting your answers in if you haven't done so already. Okay. So let me go ahead and I'll share the results with you. I think most of you have gotten your answers in, and so y'all should be able to see the results. Most people chose B on this one. Let me bring up some highlighted words. And the nice thing about a question like this is it actually tells us that the physical therapist suspects adhesive capsulitis. And the other words that are in red font are things that would make us think about adhesive capsulitis, but really what the question is asking is which is the best choice of PT interventions for the disorder? This question is a straight up um, test of our knowledge of the evidence. And well, we often do joint mobilization and some of the other things that are listed here. The highest level of evidence associated with intervention for the person with adhesive capsulitis is actually stretching exercises. It's stretching exercises and patient education. And so I'm going to jump ahead. We'll just kind of keep in mind these answers. Two modalities, E-stim and ultrasound. The joint mobilization is, yeah, in the clinic, that's a popular intervention. But look at what the clinical practice guideline says. And I know that up at the very top of the screen there that it says 2013, but there was a more recent update of this CPG. And so, yeah, grade B evidence, stretching exercises, and patient education. And that trumps grade C level evidence, which would include the joint mobilization and then modalities. And we had a couple of answer options that were modalities. All right. So, yeah, we need to, right? We need to be familiar with what the evidence says for questions like this on the NPTE. And I mentioned a little while ago those clinical practice guidelines, and I have most of them that are listed on this slide, and the dates are a little bit out of order and everything. But yeah, there are probably, I don't know, around 15 to 20 clinical practice guidelines that are published in JOSPT, Journal of Orthopedic and Sports PT. And again, they're nice one-stop shopping for, everything you want to know about, the management of low back pain. What am I going to use to examine my patient? What am I going to use to treat my patient? Those kind of things. They're in the clinical practice guideline. And when it was updated in 2021, they kind of broke it down to they broke it down based on, whether it's acute low back pain or chronic low back pain. And so let me look at the chat box real quick. So Kristen, yeah, yeah, joint mobilizations are a popular treatment in the clinic, and I mean, there's still some evidence to use them, but knowing the natural history of adhesive capsulitis, what is a popular intervention is to to teach the patient about the condition, so patient education, and you can place them on a home exercise program with some good stretching exercises. Maybe check in with them fairly regularly to make sure that they're making progress and that they're demonstrating the techniques properly and that kind of thing. But yeah, those two are going to be higher level evidence than mobilization. And so yes, so Zoom user, I'm not sure what your name is, so I'm gonna call you Zoom for the time being. But even, yeah, corticosteroid injections, that's the highest level of evidence. Now, granted, that's not within our scope of practice, but that's the highest level of evidence for actual interventions. So we may, thank you, Kelly. Yeah, so we may do, a patient might get an injection, and then we're going to see him and we're going to start him on stretching and do the patient education and all that kind of stuff. So, all right, everybody good on that? Sure thing. Okay, we'll go on. Question number two. your answers in. So while y'all are finishing up, I'll go ahead and bring the highlighted words in and everything. And the nice thing again about this one is it tells us the patient was referred with a diagnosis of Achilles tendinopathy. Well, just like what happens in the clinic, we still need to make sure that that person does indeed have Achilles tendinopathy, but the rest of the question stem is pretty consistent with that disorder. Again, the nice thing about a question like this, sometimes with other questions, they're really two-part. You've got to come up with a diagnosis based on the question stem. So you got to figure out what the diagnosis is, and then you got to figure out what the appropriate intervention is going to be too. Um, but here, yeah, it says Achilles tendinopathy for the referral, but then the rest of it, initial pain when running, resolves after a half mile, returns a few hours after the run. The insertion of the tendon, so on the calcaneus, is tender to palpation. Patient's pain is reproduced when performing a single leg heel raise. That all, right? That all feels like Achilles tendinopathy, sounds like it, smells like it, the whole bit. And so, which is the best intervention to decrease pain and improve function in a patient with this disorder? Well, I have to admit, I'm going to ask you 7 questions, and really, I think 3 of them are kind of based on clinical practice guidelines. So the correct answer to this one is based on the Achilles tendinopathy, CPG, and that correct answer is what most of y'all chose. So great job on this one. About 2/3 of you got it correct. And so there is strong evidence. I'm looking ahead at the table. I'll bring that up in a minute, but there is strong evidence to support eccentric loading of the ankle plantar flexors to both decrease pain and increase function in patients that have an Achilles tendinopathy. And the patient in this case, kind of based on what is described, is likely able to tolerate high eccentric loads because it seems like in terms of severity and irritability, they can run. It resolves after about a half mile, and so they're probably going to be able to tolerate that exercise pretty well. There's no evidence really either way to support or refute strengthening of the ankle dorsiflexors. It's kind of like, I mean, it wouldn't hurt to do it, but if we're gonna think about the biggest bang for the buck, it's going to be that eccentric exercise of the ankle plantar flexors. And there's actually some weak evidence to support stretching of the ankle plantar flexors and doing the soft tissue mobilization. And so let me go ahead and bring this. We'll bring the table up. Now, I just wanted to share with y'all, and some of y'all may be familiar with it, and I know this is probably going to get a little bit blurred, but this is the Therapy Ed Review and Study Guide. So it's our review and study guide to help students prepare for the NPTE. And this table is actually a summary of the Achilles tendinopathy. You can see the reference down at the very bottom. It's been revised since then or updated since then, but it's the just a little snapshot, the intervention portion of the clinical practice guideline. And what we do is we place in bold font anytime there's grade A or level 1 evidence, right, in those tables. So we try to get your eyes to go to that part of the table where there's really strong evidence. You could see questions that are based on, grade B or C or that kind of thing. But yeah, use mechanical loading, eccentric or heavy load, slow velocity exercise to decrease pain and increase function. And that was indeed the correct answer. And then you can see some of the lower level evidence that were the other answer choices here too. All right, we'll go ahead and move on from this one if you're all good. Okay, question number 3. Oh, I'm sorry. I didn't share the, my bad. I didn't share the results. There's the results from the last question. So take a quick look at that, and then I'll stop sharing and relaunch the poll. All right, let's go ahead and move on to the next question. Completely forgot to start my watch on this one. So let's take about 20 seconds, 20 to 30 seconds to finish up, and then we'll take a look at it. Okay, y'all go ahead and finish up. All right, so here we go. So here are the results. It looks like most people were thinking about answer three or C. And on this question, what we do have to do, we got to come up with a diagnosis first, right? And then think about what the appropriate intervention should be. So in this one, what y'all go ahead and light up the chat box rather than me just telling you what do we think is the diagnosis? What kind of injury did this person sustain? Anybody want to take a stab at that? Yeah, exactly. Yeah. So we're dealing with an acute hamstring strain and exactly. So well done, y'all. This and a key part of it too is we're seeing the person 24 hours after injury, right? So we've got to proceed kind of cautiously and tenderly, and we're still in this, this kind of protective part, the acute inflammatory stage. And so yeah, this person has sustained an acute hamstring injury. So it says which intervention is best to use when initiating therapy. And I'll just jump ahead. So great job. 72% of you got this one correct. And I suspect that most of you or many of you who selected that focus on the fact that it said we're going to do things within the pain-free range, right? And they're one day after the injury. So again, acute inflammation, and we want to proceed gently. We want to allow the condition to calm down a little bit. We want to allow things like cross bridges to start forming within the muscle and some of the connective tissue and everything where the injury has occurred, and that's going to occur over probably a period of about 4, 5, 6 days. Um, so let's see, a number of people chose number one or number four on, and I'm going to lump number two and number four together because if we do active or resisted knee flexion, if we make the hamstrings work, that's going to be painful for the patient. And more than likely, we're going to disrupt what we want, that all the stuff that's happening with the acute inflammation, which is a necessary part of the healing process. So we want to let things settle down. Let's do things in the pain-free range. They can kind of do, they can be sitting up on the treatment table, do almost like heel slides, then flex the knee as far as they can comfortably, then go back down to extension and just try to maintain muscle length, knee and hip range of motion and those kind of things. Now, cross friction massage is certainly something that we do as an intervention for people that have had a hamstring injury, and we do that to prevent uh, scarring and adhesions and make sure that that person maintains their muscle length and flexibility. But we are not going to do that 24 hours after injury. We do cross friction massage. We get in there and get after it, one day after injury. That patient may not be coming back to see us, right? When do we do that? We do that maybe 2 or 3 weeks down the road. And again, to try to manage or prevent adhesions and scarring and that kind of thing. So here's, when we talk about ecchymosis, this is that bruising, like we can see on this picture of this individual. And then this question is based on soft tissue healing timelines. So again, with interventions, we want to think about those healing timelines. And we could apply the same principle to other systems. Like let's think about, the neuromuscular system. What do we think about the person who's recovering from a stroke? There are these distinct stages that they go through, just like with a soft tissue injury, there are these distinct stages that the person is going to go through as well. All right. So that's what that question was based on. Okay. Question number 4. Okay, go ahead and start finishing up and get your answers in. Okay. All right. So y'all can see that number 2 was the most popular answer, and let's work through this one. So this patient has a 1 week history of low back pain. It radiates into the buttock and the posterior thigh. Usually, if somebody has nerve root impingement for, that traction may be effective for. Um, so if somebody has a radiculopathy, if I use, somebody has a S1 or a L5 radiculopathy, something like that, then their symptoms are typically they're gonna radiate distal to the knee, and they may complain of numbness and tingling if it's a S1 radiculopathy, maybe along the lateral border of the foot into the little toe, or maybe on the, in the middle of the foot, kind of numbness and tingling in that area if it's a L5 radiculopathy. But this only radiates into the buttock and posterior thigh. And so a lot of things can kind of refer pain into that area. So physical examination findings include limited range of motion in all directions and hypomobility. So hypomobility or stiffness or limited motion noted on posterior to anterior PA glide. So like when we're doing those PIVMs, right? From L4 to S1. So we got these segments L4, 5, and then from L5 to S1, we encounter stiffness, we encounter limited motion. So, based on these examination findings, the PT determines that the patient will respond favorably to which treatment approach. And what the majority of y'all chose is indeed the correct answer, right? And so, spinal manipulation, they're stiff, they've got limited motion. Let's go ahead and move them. Okay. With stabilization exercises, we would have expected to see, something that makes us think about instability or maybe a positive PIT, prone instability test or something along those lines. Again, lumbar traction, we would have expected to see some clear signs of nerve root impingement or maybe a positive straight leg raise, positive crossed straight leg raise. An extension exercise, we would have expected to see something in the question stem that tells us that this individual actually has a directional preference of extension. Maybe their symptoms centralize with doing prone on elbows or some kind of extension maneuver, but we didn't see that. What we did see is that this person is stiff, they got low back pain. We find hypomobility on our examination, and so moving them is going to be the answer. And I think this is the last time I'm going to bring up the clinical practice guidelines. But here's what the one for acute and chronic low back pain says. And this is grade A evidence, right? So physical therapists should use thrust or non-thrust joint mobilization to reduce pain and disability in patients with acute low back pain. And the same thing with chronic low back pain. And now, also in that clinical practice guidelines, it talks about clear indications for things like nerve root impingement and I think directional preference and that kind of stuff. So, all right. So I would encourage you to take a look at that. It'll, if nothing else, kind of in these final weeks of preparation, if you're going to take the examination in January, it'll help you focus your study efforts on what the points of emphasis or, I was in the military, I got a lot of military terms backed up in me. It'll help you identify some of those high value targets that will likely appear on the NPTE. All right, we'll move on to number 5. Here we go. Take a few seconds to finish up. Get your answers in. All right, here we go. Take a ride in the cash cab. All right. So, it looks like a lot of people chose number three on this one. And let's take a look at the question. So, it's a question about a patient that has fibromyalgia. So, we're going to put together an exercise regimen for this patient, and we got to take into consideration, what's going to be the most important factor. What is true? So, really, you can almost look at this question like there are four statements and they're almost like four true false statements. So what is the one that is true? That's yes, that's a factor that I want to consider. And which of the others are either just incorrect or it's not something that we're really going to take into consideration. So I will jump ahead and spill the beans, or what do y'all say? Y'all say spill the tea nowadays, or something like that. So did I use that correctly? If I'm like an old guy and I just use that completely incorrectly, then I'll stick with the old phrase, spill the beans. So I'm going to go ahead and spill the beans. Okay, thank you. Thank you for the love, Mackenzie. But yeah, patients with fibromyalgia have difficulty with sustained overhead activities. Okay. That is absolutely correct. And we think about the person with fibromyalgia, they have, they're tender in 11 for the diagnosis, 11 out of 18 tender points are kind of trigger points. That's part of the diagnostic criteria. And some of that, that'll include like our postural muscles, trapezius, intrinsic back muscles, that kind of stuff. So doing sustained overhead activities, that becomes problematic and can become painful for the individual. So let me just, yeah, there are a couple of notes here that I wanted to share. So not only will they have a hard time with overhead activities, but they can have a hard time with vigorous or high impact activities. They also tend to be vulnerable to overdoing exercise sessions. So we need to monitor them and make sure, we're seeing how are they responding to the session. And it's probably better to progress and slowly err on the side of doing too little during a session, especially early on when we're working with them, rather than risk having the patient drop out of the exercise program. So aquatic programs, number one says they have difficulty with aquatic programs. They're actually very effective for the person with fibromyalgia. I think the buoyancy of the water and the reduced weight bearing and that kind of thing can be very beneficial. Um, and then number two, uh, group sessions may actually increase compliance with the regimen, not decrease compliance. And the most popular answer from you all was number three. But what I encourage you to keep in mind is about 85% of patients with fibromyalgia have sleep disturbances. They don't sleep very well, and getting going in the morning is pretty tough. All right. So, for that reason, number three is incorrect. And for all those reasons, number four is going to be the correct answer on this one. I wouldn't expect you to see a whole bunch of questions on fibromyalgia. Maybe one, maybe potentially two on the NPTE, and maybe one that deals with diagnosis and what are some of the things that we associate with fibromyalgia. And then there could be one that's like an intervention question like this one. Okay, we got two more questions to go and about 10 minutes to go for our session this evening. So here we go. Question number six. Go ahead and finish up. All right. So a lot of people chose number four as the correct answer. Really? Number four? Y'all are thinking number four is the correct answer? You are correct. So sorry, I just had to have a little bit of fun with you. But yeah, so I said a little bit earlier that regenerative medicine techniques are new for the thank you. You appreciate my humor, Sashka. Appreciate that. But yeah, regenerative medicine techniques, so PRP, injections, MACI or ACI, stem cell therapy. Those are all things that you need to prepare for. You're likely going to see maybe a couple, probably a couple questions that deal with that across the systems and everything. Thank you, Katie. But the thing that we need to keep in mind is patients are typically going to be advised to stop the use of NSAIDs because NSAIDs will diminish, they have an inhibitory effect on platelets. And so patients may be able to continue with some COX-2 selective NSAIDs, but as a general rule, aspirin, acetaminophen, and NSAIDs tend to decrease platelet count. So we want to back off of those. And yeah, the other answer choices here are going to be incorrect, just because we want to stop, and the other three all have the person continuing or the patient continuing. Could be decreased, could be increased, could be no change, but we want to stop altogether, or that patient needs to stop altogether. All right. And that brings up an important principle, test taking strategy when you're answering a question like this. And that is to keep in mind that if you're unsure about an answer, a good strategy is to not every time, but to sometimes look for the unique response. And number four has them stopping. The other three, they're all continuing, right? So you may have a little bit of a hard time choosing between one, two, and three, but number four is clearly a distinct response from the other three answer choices. Okay. All right. Okay. Little mini drum roll. Here is the last question of the evening. Sure. Answers in over the next 10 or 15 seconds. All right, here we go. So, okay, I played a little bit dirty with y'all on this last question. All right, and um, this is not a musculoskeletal condition that we're looking at. Does anybody want to take a stab at what was actually being described? Do y'all know what do you think is this patient's problem? Can you go ahead and light up the chat box and let me know? And yeah, triple A, abdominal aortic aneurysm. That is exactly what we were going for, or what I was going for, right? And so, yes, it's a little bit of a curveball. Like I said, I was, playing a little bit dirty with you with this last question, but I just wanted to make sure that you're thinking on your feet. Low back pain is a musculoskeletal condition, and an abdominal aortic aneurysm can masquerade as low back pain. Anything, any anatomic structure like the kidneys or the abdominal aorta or the colon or part of the pancreas, if they're injured or diseased, then they can masquerade as low back pain. And so we got some of the things here that would make us think that. Number one is 65-year-old male, as we're going to see coming up in a slide. That's a risk factor. Throbbing, a throbbing descriptor that says, their pain described as throbbing or pulsating. We tend to think that is going to be a vascular origin. There are no specific factors that aggravate or ease the patient's low back pain. That's unusual, isn't it? When we talk about AGs and eases, right, that a typical patient that comes into our clinic with low back pain, they're going to say, it feels better when I do this, it feels worse when I do that. But what is being described here is this person's symptoms are pretty constant because the therapist is also unable to change them with any kind of position changes, functional tests, or other maneuvers. So they're trying to move them around and everything, and they're unable to change the person's symptoms. So they're constant throbbing, pretty significant, 7 out of 10. And so, yeah, an abdominal aortic aneurysm is what we were going for here. So we're not going to treat them. As a matter of fact, we're going to take care of them on an emergent basis because take a look at this. And let me just say real quickly while the answer choices are up here. The second most popular answer, so great job. Almost 80% of you got this one correct. Um, on number 4, that was the second most popular answer, recommend an x-ray to rule out a possible lumbar spine fracture. If that person had a lumbar spine fracture, then when we were doing those position changes, functional tests, and everything else, we would have lit them up, right? And we would have provoked their pain. And so that is an orthopedic or musculoskeletal problem. But what is being described in the question stem is not. It is a vascular, systemic problem. And so, you may recognize this CT it's from an article by, I think it's William Boysenalt, Bill Boysenalt, who author of the book. I'm trying to look for his textbook over here. Yeah, Primary Care for the Physical Therapist. But in this CT, there's the heart, there's the aortic arch, the descending aorta. This is not the stomach, that is the aneurysm, right? And in this anterior view, that is the aneurysm. So people may walk around with an aneurysm like that. Who knows? Maybe they walk around for a couple of months or so. But if they walk into our clinic door, through our clinic doors, we got to be good at picking up on these signs, these red flag signs and everything else. Because if that thing blows, that person is likely dead. They're going to pass away, right? Because they're going to bleed out, and it's unlikely that they're going to be able to get taken care of. And, especially if we're an outpatient clinic, we got to call the ambulance and all that kind of stuff. And so we got to pick up on some of these signs and symptoms like the words pulsating and throbbing, and males more so than females, 6 times more so than females, age over 60 years, uh, age greater than 60 years, and other cardiovascular risk factors. All right. So we got to pick up on that, and then we got to get them taken care of right away. So this would be an emergent condition. And so folks, y'all did a good job. I think we had maybe one speed bump kind of question, maybe one or two of those, but I think for the most part, y'all did a really good job answering these questions this evening. And so just kind of in summary, you know, I told you what some of the interventions questions could be based on. And so what we saw here tonight are all the different categories that are listed in red font. We didn't see one that is based like on the centralization phenomenon or exercise prescription, post-op stuff, pharmacological management. Well, maybe pharmacological management, we need to cease the NSAIDs for the PRP injection. Katie, I'm not sure what you're asking. How do we send on questions? I'm not, um, still not sure what you're asking. I don't know. Are you asking how you can see the questions again or like in the future? Or this session is going to be it is being recorded, so it'll be posted to Therapy Ed's PTU. Are you able to send in questions? You mean like for us to consider using? Is that what you're asking? I'm not sure what you're asking. I'm sorry. Anyhow, I'm going to share my email address with y'all in a little bit. Or as a matter of fact, let me put it in the chat box. So if I misunderstood anything, then here is my email address, and y'all can fire away. If you got anything I can do to help you prepare for the NPTE, then go ahead and send me an email. I'm going to just finish up. I've got a couple more things, but yeah, you won't be able to see the questions again other than on the YouTube video. And so anyhow, but I can go ahead and respond to you on email. Yeah, so you can go to this slide just lists our Therapy Ed resources. So we just want to make sure that you're aware of those. So our review and study guide, we have a 2-day prep course that may help you. Online office hours, that's what you did this evening. And then there's the app that is available to you as well. So that's on our website. Um, there's no session for the next 2 weeks because of the holidays. But then starting in January, we have a variety of topics. So neuromuscular topic, which would be pediatric reflexes, that's coming up on the 7th of January. GI system on the 14th. And then the cervical spine or neck pain clinical practice guidelines that'll be a popular one, for the musculoskeletal system as well. And so, with that, folks, yeah, I see a number of you that have said thank you and everything. Thank you. We appreciate y'all being here. I've enjoyed spending this past hour with you, and best wishes for success on the NPTE. It was good to see a number of familiar names and faces this evening, and hopefully we're going to see you. Hopefully we're going to see you coming up in the coming weeks. So, yep. Thank you all. Happy holidays as well, and have a good night. Goodbye.